All right. So what the title of the talk today is why routine screening is important. And when I'm talking about screening, I'm not talking about all screenings. I'm talking about colon cancer screening, which is what I take care of all the time. It's kind of my mission in life to take care of colon cancer and try to prevent it and cure it. Just so you understand who I am, I'm a colon and rectal surgeon. This is a slide just tells you what a colon and rectal surgeon is. We're specially trained surgeons that take care of really the intestine, small intestine, large intestine, rectum, and the anus, and the area around the anus. It takes a long time to become a colorectal surgeon. I went to 4 years of college, 4 years of medical school, 5 years of general surgery training, and 1 year of colorectal fellowship. That's it, the minimum. And I actually did a couple extra years. I did extra year of minimally invasive training. So at any point you guys want to get me to stop and clarify something, please do. We take care of all kinds of diseases of the intestinal tract, small bowel tumors. We take care of something called inflammatory bowel disease. You might have heard the terms Crohn's or colitis. We take care of diverticulitis, a very common disease that affects the colon. We take care of different kinds of cancer, colon cancer, rectal cancer, anal cancer. We also take care of what's commonly referred to as proctology, problems of the anus like hemorrhoids, fistulas, fissures. Take care of genital warts. And I also do colonoscopy, sometimes for diagnostic and screening purposes, and sometimes for interventional, try to do something like remove a polyp. Yes.
I've never seen the word diverticulitis before. What is it and how is it manifested?
So diverticulitis is extremely common, more common than colon cancer. It's a disease that affects the colon. And I'm actually going to tell you a little bit more about the GI tract and what is the colon. But the colon is also referred to as the large intestine. And it's the last part of your GI tract just before the rectum. And over time, with the aging colon, you can develop these little outpouchings. They're like little pockets. And those pockets, most people, by the time we're 60 years old in the USA, 50% of us already have diverticulosis, which means to have the pockets but not have any symptoms. If that pocket gets clogged with stool and it traps bacteria, that can create an infection in the colon. The most common symptom for diverticulitis is pain in the left lower quadrant. It's a pain that won't go away. It's almost the opposite of appendicitis. It feels just like appendicitis. Sometimes people confuse it, but it happens on the left side instead of the right side. So if you're having left lower quadrant pain, it's not getting better, especially if you start to have fever or something like that, you should call your doctor, okay? Sure. So diverticulitis, while you have active inflammation, sometimes patients will become very constipated. But actually, chronic constipation puts you at higher risk for diverticulitis. So people who have a slow colon, they tend to get diverticulitis more. The diverticulosis in other parts of the GI tract is a different process. The diverticulitis in the colon usually develops over time. You can get diverticulosis in the small intestine and even the esophagus. You're usually born with those diverticulum, though. Those are congenital, not acquired. Okay.
And can the pockets that's there from diverticulitis first?
Yes. So that's the most extreme. So people with diverticulitis usually is a pretty patient has pain in left lower quadrant, lasting a couple of days. They see their internist. He says, "Oh, you have diverticulitis." Put you on antibiotics, and usually in about 48 hours, you feel better. Some people, especially if they're tough, they're sticking it out, they don't want to go to the doctor, that can keep getting worse and worse until it ruptures, and then it actually could be fatal, or we have to operate. I always say in the middle of the night. I'm always operating on this in the middle of the night, taking out a piece of the colon, and you can end up with a colostomy, which nobody wants. All right. So we're here really today to talk about colon cancer. I want to give you a little idea what is it, and the things I think that the average person should know about diverticulitis. I want to talk a little bit about screening. Why do we do it? Why does it work? What's the thought process behind screening? And then talk a little bit about different ways to do screening and what the current recommendations are. Did you have a question? Mm-hmm. Hereditary? Yeah, I'm going to talk all about that. Yes, it's pretty. So, I think when doctors say colon or large intestine, sometimes we're assuming people know what we're talking about. And I've always tried to be the kind of doctor, I don't want to assume anything. I want you to, whatever time it takes, I want you to understand what I'm telling you, what it means, so that you, and that's, I think the people in this room obviously have a curiosity, but some patients are intimidated or not, or don't think to ask questions. I want people to have that curiosity so that when we're taking care of a problem, we're taking care of it together. I don't want you to be just a passive recipient of care. I want you to be active in your care, active in decision making, et cetera. So anyway, this is a picture of the GI tract. I don't think the red dot's not. Oh, so when you eat food, digestion starts in your mouth. You have enzymes in your mouth called amylase, starts dissolving sugars. The food comes down your esophagus. Not much happens in the esophagus to your stomach. The stomach secretes acid, and the acid helps to break proteins. After the food is out of your stomach, it goes into the small intestine. This kind of looks like sausage. This is the workhorse of the GI tract, the small intestine. All the nutrients are absorbed there. So protein, fat, carbohydrates, vitamins, minerals, all absorbed here. And then it gets to the end of the small intestine, which is about 20 feet long. That connects to the large intestine. So if I say large intestine or colon, I'm saying the same thing. Those are synonyms. It means the same thing. So when that stool gets there, the nutrients are up, but the water has not been absorbed. So the colon is about a 5-foot long pipe that absorbs water. That's its job. So when you drink water, it's actually not your kidneys that are absorbing, your kidneys filter. Your colon's absorbing the water. And then the last part of the colon is the rectum. It's still part of the colon, but it has a little specialized function. And then when the stool has to pass out of your body, it has to pass through the anus. So we're really talking about cancer that happens in the large intestine or the colon. All right. So why I want to talk about this is because colon cancer is common. It is the second leading cause of cancer death in the United States, only behind lung. If we took away smoking, it would be number one by far. If you look specifically at men, it falls behind prostate, but only men can get prostate. So number 3 in men, and also number 3 in women, behind breast. But altogether, it's the second most most common cause of cancer death in the United States. So every year, at least 150,000 people are diagnosed with colon cancer in the United States. That's just the United States. And 50,000 people die. That means about 1/3 of us are not going to survive that diagnosis, which is really sad to me because most of those patients never had to have colon cancer had they had screening. So your lifetime risk, even if you have no family history, because people say to me all the time when I'm taking care of their cancer, Doc, no one in my family has colon cancer. Why do I have it? We don't know why that is. It's a very complicated answer. The environment, our foods, things like that. But for an average risk person, someone who has never had a family history of colon cancer, still 4%, almost 1 in 20 of those people are going to get colon cancer. So this is a big public health problem, and it affects all walks of life. There are some things that we know seem to increase. These are the risk factors. Colon cancer becomes more common as we get older. If you have a family history, especially a first degree, brother, sister, father, mother, that's a risk factor. People who have low fiber diets and low in other nutrients. Obesity is tied to many cancers, including colon cancer. Alcohol is, smoking is, inflammatory bowel disease, which I mentioned earlier, Crohn's and colitis, and then also exposure to radiation. When it comes to ethnicities, there are some specific risk factors. The Ashkenazi Jews are the highest risk of colon cancer. They have more colon cancer than any other ethnicity. Native Americans have the highest rates in the United States. Pacific Islanders, like people from Hawaii, they tend to get it at a much earlier age. And actually, African Americans, up until recently, used to get it less often than Caucasians. But when they got it, had much more severe and much worse prognosis. But that's changed. For some reason now, African Americans and Caucasian population have similar rates of colon cancer, but still mortality is worse in the Black population. So what are signs and symptoms? First of all, I want to say signs and symptoms are too late. You don't want to wait till you feel these signs and symptoms to look for help. the most common ones are change in bowel function. People said, oh, I used to be irregular. I used to go to the bathroom once a day. Now I'm not going for 2 or 3 days, and I feel bloated. I feel abdominal pain. My stool is changing in shape. It used to be a good caliber. Now it's very thin. It's pencil shaped, or looks like it has flattened out on one side. I'm seeing blood in my stool, and unexplained weight loss really bad. The most common way we actually find it at the doctor's office is the patient goes to the doctor, says, I feel tired. I can't walk up the stairs. I'm short of breath. We do a blood check and they're anemic. And then what we find is an iron deficient anemia. So people who have colon cancer are constantly having a small amount of bleeding in their intestines and they become anemic. And then that's how we often find colon cancer. So why screen? So as I mentioned, we're screening because it's very common and it's potentially lethal. And if you follow the guidelines and you get screened when you're supposed to, you decrease your risk by more than 80%. That's the best screening that we have in all of medicine is colon cancer screening. So here, why does screening work? So colon cancer doesn't happen overnight. What happens is the cells in the lining of the colon, which is a very hostile environment, right? That's where the stool is. They constantly have to change. They start to undergo genetic changes and they grow too fast. And when they're growing too fast, they become a polyp. So a polyp is a precancerous lesion inside the colon. So it's a precancerous finding. It's not cancer yet, but it's moving towards colon cancer. And the process from going from a normal cell all the way to colon cancer, we think takes at least 8 to 10 years. So if I can come and find this polyp and remove it, so this is a cartoony picture and this is actual polyps, and I can remove that polyp while it's still in the pre-malignant phase, I killed that cancer dead in its track. I stopped you from ever having a colon cancer. And now we also identify you as someone who has higher risk because you had pre-malignant polyps. So so your screening becomes shorter and a little bit more intense. I put this slide on just to show you when we're doing colon cancer, when we're doing colonoscopies in asymptomatic patients, we talk about screening for colon cancer. We're really screening for polyps, but sometimes we find asymptomatic cancers. Earlier stage cancers are more likely to be asymptomatic and are way more likely cured. So sometimes I do a colonoscopy, I find a cancer, and the patient says, oh my God, I felt fine. And usually it's an early stage cancer and we can still cure it. So that's why I put this slide. So screening has been in existence for decades. And some of this is a little kind of historical, but I just want to tell you what's out there because there are still parts of the country and other parts of the world that don't have the same access to colonoscopy, which is where I'm going to talk about a lot in a second. So I don't know how many of you ever went to your doctor and they give you these little cards. So I'm going to go back. So these are a list of them. So the fecal occult blood test, I'm going to actually talk a little bit endoscopy. I'm going to really talk about colonoscopy, but flexible sigmoidoscopy is mini colonoscopy. Stool DNA testing is the new thing, which is Cologuard, which I always get a Cologuard question. And then there are some imaging, meaning things where you can go to the radiologist and have some kind of imaging study. So we'll start with fecal occult blood testing. So this was very popular, and still a lot of doctors will do this starting in the 40s. They give you a little cards with little instructions, and this is the kit, and they say, you're going to go home, and 3 consecutive bowel movements. You're going to take this little, looks like a popsicle stick, and you're going to rub that on the slide. You're going to put a little developer on. You're going to bring them to me. So this is looking for blood in the stool. It's not very sensitive, and it's not very specific. It can miss. It actually usually misses polyps, and even with cancers, it misses a lot of cancer. So it's not perfect. It's better than nothing. So flexible sigmoidoscopy, almost not done anymore. But when I was in training, this was still common. It was a mini colonoscopy. So you'd go to the doctor's office, you didn't get any anesthesia, and they put you on the table and they put a scope in. They only can look at about 1/3 of your colon. And the advantages over colonoscopy is you didn't have to do the full laxatives. You just had to do an enema. But the problem is we're missing 2/3 of the colon. And if we found a polyp, then you had to go have the full colonoscopy to see if there were polyps other places. So not commonly done anymore. Some doctors, and there was a good data on this that put together, if you were doing the cards, the fecal occult blood testing every year, and the flexible sigmoidoscopy every 5 years, this combination reduces your risk by 43%. But remember I told you, current screening, we're reducing risk by more than 80%. So this was okay, but still imperfect. So there are some people say, can't I just get an x-ray, doc? So there are x-ray tests. Once upon a time, we used to do these double contrast barium enemas. So what would happen is you'd have to do laxatives. Then you'd go to not the colorectal surgeon, to the radiologist. They would first fill your colon with barium. They had to put a tube in your bottom and squirt that in there, empty out, and then squirt air. So that was a pretty terrible test. Messy, unpleasant, and very imperfect. It also could miss small polyps, and sometimes if people still had stool in there, it would interfere with the quality of the test. So when I was in training, this became popular. They started talking about virtual colonoscopy. Oh, you're not going to need to do a colonoscopy anymore because you can just get a CAT scan. Same thing, you still have to do a bowel prep, and instead of putting contrast into your colon, they still have to put a tube in and blow air into your colon. So you still have to go through the bowel prep. And then if they see something funny, you still have to have a colonoscopy. So this kind of came and went. It was in the journals. Everyone said, oh, I'm going to get my virtual colonoscopy. And now it's almost never done. There are very specific reasons why we might do it, but it's kind of beyond the thought. So colonoscopy is the gold standard. Most communities in the United States have access to colonoscopy. Colonoscopy is basically a long tube. I have a camera on the end of that tube, and I have little channels I could put instruments through. And I could put the scope in your bottom and slowly advance it to the very beginning of your colon and look for polyps using that camera. And I can usually remove the polyps. So you do have to do the bowel prep the day before. That's the thing that patients most of the time complain to me about is, oh my God, I have to do those laxatives. To me, it's no big deal. One day of diarrhea is not so bad. You get anesthesia, so you're comfortable during the exam. And then you just have to take a day off from work. It takes 30 minutes because you have to rest because of the anesthesia. Most people feel perfectly fine and back to work or whatever their normal life requirements are the day after. So here's another picture. So this is the picture of the colon. There's the camera I'm putting in, and I'm looking at the TV screen. So they found that when people have a good colonoscopy, so this they're trying to figure out when the colonoscopy first came into existence, how good it was of a test. If you had a good bowel prep, meaning your colon was washed out well, and we saw no polyps. When they repeated a colonoscopy in 5 years, there was less than 1% chance of even having a cancer. So the recommendation became, if your average risk, and I'm going to talk about this again, meaning you don't have any family history and you've never had polyps, if you have a good colonoscopy, we'll see again in 10 years. Not so bad. Some patients will come to me and say, I'm afraid, doctor. I've heard of somebody, my aunt, my neighbor, their colon got punctured. And I'm afraid of that. So that is a real risk, but it's very rare. It's somewhere around 0.3 to 0.02. So most of us tell us about 1 in 8,000 risk. It's very uncommon. And I will tell you, because I'm a colon surgeon, I end up fixing other people's ruptures. Usually means there was something wrong with that colon. They were doing the colonoscopy, they were trying to remove a big polyp, or there was diverticulitis, or there was a narrowing. Healthy colons don't get ruptured during colonoscopy. So a lot of people, because they don't like the idea of anesthesia, they don't like the idea of having a procedure, and don't want to do the bowel prep, say, what about this Cologuard? This has become very popular. So Cologuard is better. Did you have a question, sir?
Yeah, I want to ask, what is healthy Cologuard?
When I said healthy, it means I didn't see any polyps. Okay. And I usually comment on other things to people. I tell them if they have diverticulosis or not. I tell them if they have hemorrhoids or not. But if you have diverticulosis hemorrhoids, doesn't mean we need to do colonoscopy any more closely. If I remove a polyp on you, that means now I know you had the right, you can put it whichever way you want, the right combination of genes, the wrong combination of genes to have a pre-malignant polyp. So I'm not going to let you go 10 years. I'm going to want to see you again in 5 years. Okay. So that's what I mean by healthy colonoscopy. So Cologuard, better than nothing. Cologuard it combines that looking for blood in your stool with a new thing, which is where they look for tumor or polyp DNA in your stool. There's a couple things I don't like about Cologuard. So number one is there's false positives. So I've actually had patients come into my office crying Why are you crying? I say to them, because I have colon cancer. I said, why do you say that? I did a Cologuard test and it was positive. I said, that doesn't mean you have colon cancer. First of all, it might be a false positive. Second of all, it could be positive with just a polyp, which is not cancer, and it could be positive for cancer. It also has a false negative rate, which means it misses 8%, or almost 1 in 10 cancers. That's, in my opinion, an unacceptable rate. So I think we do use it in patients who absolutely refuse to have a colonoscopy. But if you look at what's the FDA recommendation, it says patient has to be average risk, means no family history of colon cancer, had never had polyps, and have no symptoms. So if you're going to do Cologuard, that's, and then if you're going to do Cologuard, because it's less sensitive than colonoscopy, you just have to do it more frequently. You should probably do it, some initially said yearly, but right now I think the current recommendation is every other year to every 3 years. You shouldn't. So I don't love Cologuard, but to me it's better than nothing. So what's the current recommendations for screening? So up until, I think I mentioned in here, up until I think it was 2021 or 2022, we used to say to you, if you have no family history, then you should start your colon cancer screening at 50. What's interesting is that all the colon cancers, the incidences are dropping, including colon cancer. The incidence in people over 50, it's dropping, but the incidence in younger than 50, it's going up. So they moved the recommendation down to 45. But if you have a family history of colon cancer, you should do it 10 years earlier than that. So if your mother had colon cancer, you should start your colonoscopies at 40. If your mother or your first degree had an unusually young cancer, let's say your parent had colon cancer at 38, you actually start 10 years younger than that, 28. So that's what the current recommendations are. So what does the future hold for screening? So I've been in medicine, I guess, around 20 years now. And sometimes you think, oh, not much is changing. Things are changing all the time. And a lot of what's happening in medicine has to do with genetics. And we're starting to understand the genetics of things. And we're starting to know what genes cause colon cancer, cause breast cancer, cause other diseases. So it could be that we start looking for genes. You go to the doctor, get a blood test, and we're looking to see if you have the genes. And you might just have to have a blood test. There is this test now called Signatera, which we don't use for screening. We use it now. It looks for circulating tumor DNA. We use it in people who we know have colon cancer, and it helps us make decisions about their treatments. But I can see something like that in the future where maybe you don't have to have a colonoscopy anymore. Maybe you just need a blood test. But right now, the best test is still colonoscopy. So once again, this is kind of a summary slide. Why do I want people, or why do we recommend colon cancer screening? And it's because it's effective. That's the most important. It prevents cancer. It reduces your risk by more than 80%. And it reduces, and this is a cancer that's very common and fatal if not treated. And most of the patients I take care of, because I take care of a lot of colon cancer, when they come to me with a newly diagnosed colon cancer, I usually ask them, and not because I'm being cruel, but because it's part of their history, have you ever had a colonoscopy? And the majority, more than 90%, say, I never did it. My doctor told me to, and I didn't do it. Or some of them tell me, no one ever told me to do a colonoscopy or never to have colon cancer screening. So that's why I'm here, get the word out. It's very important to screen because this is a preventable disease. And you went from me just having to remove a polyp to maybe having an incurable disease, maybe having to have major surgery, maybe having chemotherapy, etc. So actually, that's all I have for you. Colon Cancer Awareness Month is in March, and the ribbon is blue, so that's what I put that there. Did anybody have questions for me?
Yeah. I have a quick question. If I go to the doctor and I tell them I have diverticulitis, they will still proceed doing the screen, the colon cancer screen, right? The same normal way they would do.
Yeah. So if you have diverticulosis, you're saying, not I just means you're having an infection.
I got the pop.
Yeah. Yes. So for people with diverticulosis, the screening recommendations are the same. It's just something we note during the exam. And we actually don't do a colonoscopy if you have active diverticulitis. If you have inflammation or infection, because the rupture rates go up. So if you have active diverticulitis, you have left lower quadrant pain, and we think you're in the middle of a bout, we will wait at least 6 weeks before we'll do a colonoscopy.
Yes, I was, oh, I don't need that. Questioning if if receiving, what is it? CAT scan, colonoscopy still needed?
Yeah, so CAT scans, because I have patients who say, I had a CAT scan. Why would I need? CAT scans are really, really bad for seeing inside the lining of the colon. I have patients with I always tell people every test asks a question. When I'm doing a test, I'm asking a question. Like if you're anemic and I'm doing a colonoscopy, the question I'm asking is, why is she anemic? Does she have colon cancer? The CAT scans we usually do when we're looking for something. So if we know you have colon cancer, we do a CAT scan because we want to make sure it hasn't spread other places. But CAT scan, including that CT colography, is not really considered a first-line screening. I also have patients say, what about, I went to my doctor, I'm a good patient, I go for my annual checkups and my blood work is normal. How can I still have colon cancer? Right now, we don't have good blood tests for screening any cancers, except for we do screen for prostate cancer with a blood test. Men can get a PSA. So you can have very normal blood work and still have a colon cancer. Sir?
Yeah. This is very educational, and I must say frankly, because I realize that there's no one with an entirely clean colon.
Yeah.
And I've read somewhere that at any given time, we can carry up to 3 to 4 pounds of So I'm surprised that the risk factors aren't higher. You know, for everyone, it seems to be a candidate for it.
For what? For colonoscopy?
For colon cancer.
So like I said, the average risk person, meaning someone who has no family history, still has almost a 5%, 4% lifetime risk. But the colon is actually a weird organ. It's very fascinating. I mean, of course, the focus of my practice. It's the last part of your GI tract. It absorbs water. And yes, you can have several pounds of stool in the colon. A lot of the weight of stool is bacteria. And a lot of the bacteria in your colon is good bacteria. It's actually, you're healthier if you have that bacteria. And it actually works. Remember I said really the colon doesn't do much digestion? The last step of digestion is the breakdown of fiber into something called a short chain fatty acid. And if you don't have those healthy bacteria in your colon, you can't break that down. So people who, like, you know, when you take antibiotics to get diarrhea, that's partly because you're killing your good bacteria. So I usually, if someone's on antibiotics, I put them on probiotics after they're done with the antibiotics to try to replace that good bacteria in your GI tract. Miss?
So when you said that when it's heavy, it's not good, right?
So, well,
Doesn't that mean you got your nutrients and everything is okay?
so this comes up all the time. What's normal? And normal is so widely variable, you know, because everybody knows someone who goes to the bathroom and says, I go like clockwork. I go in the morning, I sit down, I'm done, I have a good sized bowel movement. And some people go for days without it. Some people go many times a day. So normal is hard to define, but your quality and volume of stool is very reflective, meaning whatever you're eating influences that. So high fiber diets tend to produce more stool, but the stool tends to be a little less dense. It's a little softer. So that's why we recommend people do 25 grams of fiber per day at least. And most Americans, even if they think they're eating healthy, don't eat 25 grams of fiber. I personally have to take a fiber supplement because I'm a doctor. So I get up at 5 in the morning. I usually eat breakfast. Then I go to the hospital. Sometimes I'm in between cases and all I can get is a piece of pizza. I didn't eat fiber all day. So I try to eat some fiber when I go home, but I also use a fiber supplement. I actually recommend most people do it, like Metamucil or something. I like Metamucil. Mm-hmm. Sir?
I don't know if I missed it, but which are the foods that are high that you recommend are high in fiber?
So fiber is plants, right? So vegetables and fruits. It's important to get some fat and protein in your diet, but processed foods are really bad. And especially, which I love, so my favorite kind of food are like foods with like nitrates and preservatives like sausage, those kind of things are known to have an association with colon cancer. So the more servings you can have of fresh fruit and fresh vegetables, the healthier your colon's going to be. I saw Miss.
To have the colonoscopy.
I was hoping someone was going to ask because I forgot to say that. So when I trained, we used to use this number. When you hit 70, you weren't going to get a colonoscopy. I don't think that's fair. The current guideline is if you follow the colonoscopy screening, your average risk, you had one at 50, one at 60, one at 70, and they were all normal, we don't do anymore. Because you've already kind of declared yourself as someone who's not going to get colon cancer. If you're one of these people, every time I do a colonoscopy, you have more polyps, and now you're 70, and we did your last colonoscopy 5 years ago, but you look really healthy, and you look to me that you're going to live more than 10 years, we'll still do your colonoscopy. So I take age into account, but there's no cutoff. It's not like, okay, now you're 70, you're done. If you're 70, you've had 3 normal colonoscopies, yeah, I'm not going to put you through it again. But if you keep having polyps and you look healthy, we're probably going to keep going. Miss?
Request that thing makes me sick. If you request for the test, whether it's 70, 80 or whatever, you still are allowed to get the test.
So I always say, the doctor has as a doctor, my job is risk assessment, right? If I'm going to put you through a treatment, I want the benefits to outweigh the risks. So if you're like 85 and you have a really bad heart and you had never had a colonoscopy, and you're feeling okay, I'm probably still not going to do the colonoscopy for you. If you're a really good 85 and you haven't had a colonoscopy, yeah, we're going to do the colonoscopy for you.
If I think polyps.
That's the whole goal of colonoscopy.
Those 2 different methods, one lying on your side, right? And the other one on your knees. Now, what's the difference?
Oh, so I think you were talking about flexible sigmoidoscopy. So we used to have people on their knees and do the mini colonoscopy. I think that test has become pretty much extinct because it only looks at a short part of your colon, and therefore we could be missing things up. So the laying on your side is the full colonoscopy. That's usually, you do the bowel prep the day before, and then you come to the hospital or some kind of outpatient facility. You get a little anesthesia. It takes less than 30 minutes, and you usually are laying on your side. Go home that day. Yep.
Okay, say you're 70 and you already had a colonoscopy, but more than 10 years ago, say 12 years ago, and what and everything was clear, what the risk?
I think if you're 70 and you had a normal colonoscopy at 60 and you're still pretty good shape, I would do one more colonoscopy on you. Miss?
I don't need a microphone. I was told that when you go to the bathroom and when your stool comes out looking like a penis or a pickle, that it's normal.
That's what the generic normal bowel movement, but I'll tell you, some people never have a bowel movement like that. Some people move their bowels frequently and it's always kind of soft. So normal is very hard to define. They actually have a whole grading system for stools to characterize it. I don't find it very helpful. If your stool changes, that's something you want to tell your doctor about. If you say, I used to have a normal shaped stool and now they're very pencil thin, or I used to go every other day, now I'm going days without having a bowel movement, those are signs you should talk to your doctor. Start with your medical doctor, and he may or not get me involved or a gastroenterologist.
There are other conditions, right, that can cause a person to normal. Specifically, I'm going to ask you a question. Pelvic floor dysfunction.
Oh yeah, that was on my list. Yeah. So pelvic floor dysfunction is a kind of a catch-all phrase. It means your pelvic floor doesn't work the way we think it should. And when we're talking about that, we're most commonly talking about what I call outlet obstruction. So these are people who their colon works, the stool gets to their pelvis, and they can't empty. And there could be for different reasons. Yeah, well, so those patients will say sometimes like, I can't get it out. I have to use my finger. It's very large. Or sometimes they'll say I have very pebbly stool, but sometimes that can be caused by problems with pelvic floor coordination, or it can be the shape of your rectum. in women, over time, the rectum can kind of stretch out and move towards the vagina, and it can trap stool. That's called a rectocele. And that's something that we first try to manage with diet, some laxatives, and if that doesn't work, sometimes we can fix surgically. Sir?
Cologuard.
Mhm.
Your opinion about that? Some folks say they're not that thrilled about it.
Yeah, so we had the slide. Let's go back and we'll look at it. So Cologuard, to me, is better than nothing, but there's a couple problems with the Cologuard. Number one, this is the thing that bugs me the most, the false negatives. If you listen, they say on their commercial, catches 92% of colon cancers. That means it misses 8%. Colonoscopy misses less than 1%. That's a lot of colon cancers to miss. So I think it's actually been helpful. I think doctors who do what I do, like do colonoscopies, when this come out, we're like, oh no, they're gonna stop letting us, we're not gonna do as many colonoscopies. I think I do more now because what happened is a lot of patients out in the population didn't want to have a colonoscopy for whatever reason. They were afraid of the procedure. They didn't want to have the bowel prep, and they did a Cologuard and it's positive. So now they have to come see me for the colonoscopy. So I think I'm glad we have it. I think if you have a choice, you should do a colonoscopy. And I think that's what most medical societies will tell you. Colonoscopy is a better test. This is better than nothing, a lot better than nothing, but it's not as good as colonoscopy.
When you do all these things, you get about that's for Medicare. When you do all these things, did you get Medicare?
So Medicare, it's funny because when I first started medicine, I decided I was never going to think about insurance and costs to the patient because I don't want to pick something because I get paid more. And I also don't want to pick something just because you pay less. I always want to pick what's right. So yes, Medicare will almost always pay for screenings. And actually most insurances now, including the private ones, will say to you, you have to have it. You're 50 or you're 45, you have to have it because they know that the effect on public health is so great. The cost in people losing their lives and the cost of taking care of colon cancer is so great that they encourage you now, or actually sometimes insist that you have screening.
A great majority of the people that come to you that do have the cancer are people who didn't take a colonoscopy. Do they ever tell you why?
So usually at that point, they're kind of traumatized. And I don't want to go there with that first conversation, but a lot it has to do with, so I will say 10 years ago, there was a little bit more of, even the medical community wasn't doing a good job thinking about screening. We're better thinking about screening because actually some of these government mandates, like there's what we call shared savings. If you can show that you did a good job getting your patient population screened, government might actually give you better reimbursement rates. So that's kind of inspired doctors to make sure. But most of the time it's because patients said, I just didn't want to do it. Something was distasteful, but they didn't want to do the bowel prep. They are afraid of the anesthesia. They're afraid of having a complication. Yeah. No.
So that means some people are.
Yeah.
So that means that how effective is it if you're not?
So there's actually a way that we will, every time we do a colonoscopy, nowadays, most of the time we're filling out a template. It always asks about quality of prep. And there are questions to the doctor. And it's a little bit of the doctor's judgment say, was this an adequate prep or not? Meaning, do I feel confident that I saw the entire lining of your colon? And sometimes we say no. And I say, your prep was fair or your prep was poor. And we need to try again within a year. It's usually what I tell people. And if there's, so and I usually will question that patient. Did you follow the instructions? Were we unclear? Did we do a bad job? giving you the instructions. Or sometimes patients are very constipated and they take laxatives at home. And so then when we give them the prep, the laxatives don't work as good. So sometimes we have to give them a heavy duty, like 2-day prep, which I always feel bad for because that's a lot more unpleasant. But if it's, once every 5 years or once every 10 years, it's worth doing. Any more questions? Miss?
When you're preparing for this, some say you need 2 pills and some,
For the prep, you're saying?
to drink, and that's it. Then they had that big jug,
Yeah, that's cool. Like,
and
so there's newer, the prep, this is the thing, anyone who does what I do, we get lots of complaints about prep. And when I first trained, the only option was 1 big gallon of Go Lightly, which is cruel and unusual punishment. The newer preps are much smaller, and we usually split them. So you only have to take half today and half the next. Usually you do half in the afternoon before your procedure and half in the morning. There are some new pill preps, which I will tell you, I think most people tolerate the pills a little bit more. It's a lot of pills, but it's easier than drinking that stuff. I had some patients say, I can't take pills. So sometimes you have to work with patients' specific needs. Sir?
I think Gloria hit on the question I had, but why do you, being in that profession, why do you think there's such a great hesitancy in the African American community to get colon screening?
Well, so I will tell you that is a great question, and I will tell you that is a new trend in the literature. We're trying to figure out what is it? Is it because the African American community doesn't have access, or is it because they don't trust, or is there not enough? Are the doctors in the community just not doing the job of educating them? So I think that's a hard question to answer. I think for a long time now, there's definitely a difference in the African American community in their outcomes for treating colon cancer. Interestingly, 10 years ago, we used to say African Americans get colon cancer less often, but when they got it, it was worse. It was higher stage and more likely to be fatal. Now, unfortunately, you've caught up to Caucasians where the incidence is the same, but we haven't done much better. There's some studies, it could be community dependent, different parts of the country where there are doing much better, and the results are much more equivalent. But that is definitely a place where resources now finally being spent, research and trying to and outreach. So that's something we probably could spend a whole afternoon talking about. Sure.
Hey, I just want to ask a hypothetical question.
Yeah.
Being that I have some people who's within the gay community,
Yeah,
that having sex in the rectum, would that create a cancer up in there and
so I was
and mess with the colon as well?
Yeah, so I had a feeling we would ask that question today because when I trained, so HIV does not seem to increase your risk of colon cancer, but it clearly increases your risk of some cancers, including, and which one of the most serious ones or that we deal with in the HIV community is anal cancer. Now, I think when you say anal, people don't always understand the difference between anal and rectal. They're different cancers. When we say anal cancer, we're talking about the last about 2 inches of the GI tract, and it's a different type of cancer coming from a different cell because there are still skin cells there. So anal cancers come from skin cells. So when I trained, we used to say that anal cancer was 1% of all GI cancers. That's exploded in the last 2 decades, exploded. There is way more anal cancer. And it's because of the prevalence of HPV, or human papillomavirus. And interestingly, in the HIV community, if you look at HIV positive people, about 85% of them, I believe is the number, also have test positive for HPV. And when you put HIV together with HPV, you create a very high risk for anal cancer. And people who with HIV should have an annual anal cancer screening. It's different than colon cancer. It's just an anal pap smear. They put a little Q-tip in your bottom, and they look for abnormal cells. If there's no abnormal cells, then you just repeat the test the next year. If you have it 3 years in a row, I think you can go to 5 years. If that test is abnormal, you have to see someone who is knowledgeable, either a GI doctor or a colorectal surgeon who's knowledgeable in anal cancer and can look for anal cancer or for premalignant lesions or spots inside the anus. But it's a different kind of screening. And actually, I was going to say, if you ever want me to come back, I think that would be a great topic to talk about, is HPV and anal cancer. Yeah. Yeah. I think if you're HIV positive, you're supposed to have anal pap smear once a year, regardless. And then if you have abnormal pap smear, you need investigation.
Oh, okay.
What just came to mind was used to hear about people getting colonics,
Mhm.
and it just occurred to me. I haven't really been heard that much about colonics recently,
Mhm.
and is there any data relating to people who get colonics and having healthier colons and a lower incidence of colon cancer?
Yes, so that's never been shown, and I will tell you, I think so. Colonic irrigation or colonics is actually, and there's people are doing this coffee colonics or it's actually probably a bad thing to do for a couple of reasons. Number one, there is a perforation rate, meaning there are reported incidents of patients having their colon ruptured in the process of having that. Number two, I think I mentioned your colon it's like a greenhouse. It has this bacteria present, and we call it the flora, just like you're talking about the flora of the jungle. Like, what are the normal plants of that environment? Well, we have normal bacteria that we need to have in our colon. And when you do colonics or enemas, you can disrupt that normal. So I'm anti colonics. Well, it's like an enema. People do some kind of irrigation process. There's actually it's hot water, and there are coffee enemas people do. Yep. This is actually one of the best audiences I've ever had, by the way. You guys ask more questions and better questions than anybody. I have to tell you, that's great. And they're great questions. They're very important and very relevant. Well, an enlarged colon. So there's sometimes when we refer to something called a megacolon, there's different reasons for megacolon. That usually means something bad's happening in the colon.
And so how could one tell one?
Well, so I think so megacolon is associated with certain diseases like ulcerative colitis. Sometimes we see these megacolons in people who are profoundly constipated. So that be something you might investigate with a colonoscopy. There's other tests for that too.
But a large bowel movement is not indicative of having a mega.
No.
Yeah.
Want to give a laxative.
So laxatives, so in general, we don't love laxatives. So if someone comes to me for the first time, they're going to the doctor the first time to talk about constipation, the first thing I'm going to say to you is, do you get 25 grams of fiber in your diet? And here's a fiber worksheet. And if that doesn't work, I'm going to say, let's add a fiber supplement. And if that doesn't work, I'm probably going to add a probiotic. And then if you still need a laxative, we're going to start with what we call the PEG laxative. So Miralax is the safest laxative. Sometimes people take Dulcolax or Senecont. Those are only safe for Miralax you can take daily if you need, but Dulcolax and Senecont are only for occasional use. If you use them every day or frequently, your colon will stop working because it mimics the chemicals in your body that tell the colon to squeeze. So your body downregulates its ability to produce those chemicals. So then your colon becomes what we call atonic. It won't move anymore. And you become dependent on the laxatives.
That's any laxative.
So if you are constipated and you feel you need a laxative frequently, I would say Miralax is the safest one. Sir?
The 25 grams of fiber, how do you know, how can you measure?
Yeah, so that's so of course, you know, the FDA wants you everything you eat to have a label. Like, so you can look at and on your, like if you're in the supermarket and you pick up 2 loaves of bread, you got a loaf of white bread and a loaf of wheat bread. You'll see that white bread has like 0 fiber. I mean, the white bread, and the wheat bread might have 1 or 2 grams. So you can calculate that by looking at the food labels. But when we have patients who come in and they're interested, we actually give them like a worksheet where they can check, well, I ate 1 serving of asparagus today. How many grams of that? Oh, that's 8 grams of fiber. I would tell people if they say, I really want to get to that 25 grams of fiber, what's the simplest way? I say, eat a very high fiber cereal in the morning, like All Bran. You can get 8, 10, or even 12 grams of fiber from that. And then if you do 1 dose of Metamucil, that's another like 8 grams. That's almost 20 grams of fiber right there. And then just increase your number of servings of fruit and vegetables, and you'll get to 25. Sir?
One question. You say me in animals.
Mhm.
Fleet is very popular. How do you see the animals? You know.
So we use enemas for different reasons. Sometimes when people are constipated, I will recommend an enema. Warm tap water works well. Fleets, there's 2 kinds of Fleets enema. One is the same thing you would drink as if you're doing the bowel prep for colonoscopy, and the other is a mineral oil enema. I think they're okay for occasional use, but you also got to remember, I've actually seen injuries from, I've seen like anal canal injuries from inserting the enema. So you have to be very careful. It's not something you should probably do routinely. So if you're doing that because you're constipated, we got to go back to that. Add the fiber, add the probiotics.
You have a card?
I do. I think I have some cards. I practice all the way in New Haven, though. You're welcome to come see me anytime. I'm happy to give you one after.
Follow-up questions. So you might have seen what we got in our meal today.
Mhm.
Can you tell me?
I think we need a nutritionist to tell you. I'm not good at that. Yeah. Yeah. It looks like you have salad, so you have a few grams of fiber from the salad, and I don't know what else was in there. So.
A few grams.
Yeah.
Need about 20 more.
Yep. You probably got about 5 to 7 grams of fiber in there. Yeah.
That could affect your ability to go, right?
Yeah, so peristalsis is when the colon or the small intestine contracts to move things forward, and that could be part of why people are constipated. No, I mean, there are medicines we don't know why someone would have slow peristalsis, and there are medicines we use in extreme circumstances that can increase peristalsis. Believe it or not, erythromycin is one of them. It's an antibiotic. All right. Are we good? Any last questions? You guys are amazing. I have to say, I enjoyed this immensely. You're a lovely group of people. I hope you learned something.